Hi everybody, and welcome to Database Camp. In today's video, I'm going to be continuing my reading of Racism in America. So if you wanted to know a little bit more about the book, what inspired me to make this series of reading this book, Racism in America, and if you also want to listen to me reading the foreword, that's all going to be in the first video. So I'm also going to be linking my first introductory video of this series down in the description, as well as the link to downloading this free ebook. Yes, this book that I'm reading is actually free. So the Harvard University Press link is going to be down below in the description as well, so that if you're interested in reading this book on your own time, you could go ahead and do so by downloading it. The link is in the description below. So today we're going to be reading the 7th excerpt, I believe, and it's titled Seeing Patients, Unconscious Bias in Healthcare, by Augustus A. White III, MD. So a little bit of background. Growing up in Jim Crow-era Tennessee, where he trained and taught in overwhelmingly white medical institutions, Augustus White witnessed firsthand how prejudice works in the world of medicine. In Seeing Patients, a blend of memoir and manifesto, White draws on his experience as a resident at Stanford Medical School, a combat surgeon in Vietnam, and head orthopedic surgeon at one of Harvard's top teaching hospitals, to make sense of and offer suggestions as to how to combat the unconscious bias that permeates medical care. In this excerpt, he explores the bias in pain treatment given to African Americans. Unequal treatment. A 2003 report by the Institute of Medicine revealed an underside of American healthcare that most doctors had no idea existed. Here we are, the book announced, at the start of the 21st century, 4 decades after the civil rights laws were passed, and the medical world is riddled with prejudice and discrimination. The question was, how could this possibly be? In clear, dispassionate prose, Unequal Treatment spelled out the extent of the problem. African Americans and Hispanic Americans received poorer care than whites right across the board. Since the charge from Congress to the Institute of Medicine was to look at racial and ethnic disparities, the researchers and writers also examined the more limited number of studies regarding Asian Americans, Native Americans, and Pacific Islanders. Of the various racial and ethnic minorities, though, African Americans were, for various reasons, by far the most thoroughly scrutinized. Given the long history in America of racial prejudice, it wasn't a surprise that blacks were especially subject to inferior treatment. Compared with whites, they had lower rates of cardiac surgeries, fewer hip and knee replacements, fewer kidney and liver transplants. Diabetic blacks were more often amputated than diabetic whites. Non-diabetic blacks were amputated more often too. Blacks were more likely to receive open surgeries rather than the less dangerous laparoscopic procedures. Surgeons didn't operate on them as often for equally operable lung cancers. They received less pain medication for the same injuries and diseases. They were more likely to be castrated as a treatment for prostate cancer. Black infant mortality was almost 2.5 times that of white babies. The overall black mortality rate was 60% higher than the white rate. African American males in Harlem, one study concluded, had less of a chance of reaching age 65 than males in Bangladesh. I knew about most of these and similar findings from my research for the Shands lecture to the Academy a 1.5 years before Unequal Treatment came out. But to many doctors, hearing such things came as a rude awakening. I think it's a truism that most physicians try to give all their patients the best care they can. So the suggestion that the profession as a whole might be prejudiced against African Americans or Hispanics strikes most doctors who aren't focused on social issues as frustrating and inexplicable. For people with full and hectic schedules, laboring under insurer-driven financial pressures, and inundated with important new biomedical findings they need to keep up on, discrimination isn't high on the list of concerns. It's kind of a non-problem, something that doesn't involve them. Discrimination may exist, but someone else must be doing it. Or else there are large social forces at work that they, as doctors, have no control over. Poverty and education, for example. Of course, impoverished and poorly educated people will probably receive less optimal care. That's unfortunately the nature of the system. Hardly a reflection on doctors themselves. But unequal treatment drew on a decade and more of studies. And these studies had become increasingly sophisticated. In particular, many of them controlled for variables, including the effects of socioeconomic factors, education, disease severity, and access to treatment. It might be a commonplace that poor people often didn't have private doctors. That lack of insurance meant it wasn't easy for them to see specialists, that they might not be able to afford medications. But why was it then that Black cardiac patients in the same hospitals and with the same insurance as white cardiac patients received less catheterization, less angioplasty, less bypass surgery? They were even less likely to receive common heart disease medications such as beta blockers, anti-clotting drugs, or aspirin. Why was it that in one of the country's top teaching and research hospitals, Black emergency room patients were more likely to be referred to doctors who were still in training as residents, while whites were more likely to be referred to experienced staff specialists? And in my own field, just why in the world was it that African Americans brought into ERs with long bone fractures were less likely to receive opioids and other analgesics? Pain is universally interesting precisely because it's universal. Everybody has pain sometimes, and some people have pain frequently or even chronically. We've all had conversations where we've talked about what kinds of pains we have and how badly we've suffered from them. There's even a kind of general curiosity as to what the worst pains are. Kidney stone sufferers often swear that the pain of passing such things is above and beyond. Acute sciatica has its strong advocates for most painful, as do migraine headaches, but childbirth can hardly be relegated to second place behind anything, though root canal infections also make most pains pale by comparison. I'm not sure exactly where long bone fractures fit into the hierarchy, but they are, without a doubt, exceptionally painful. Let's imagine that a person, Black or white, it doesn't matter, the physiology is exactly the same, is wheeled into a busy emergency room with a broken tibia, maybe from a bad fall. The tibia, or shin bone, connects the knee with the ankle bones. It's the larger and stronger of the two bones of the lower leg. It takes considerable force to break a tibia, but when it is broken, here's what happens. The tibia, like all bones, is encased in a thin sheath of tissue called the periosteum. The periosteum itself has two layers. The outer one is richly endowed with blood vessels and what are called nociceptive nerves, that is, nerves that transmit pain. The blow that broke our patient's tibia undoubtedly caused tissue damage in the region, and the broken bone ripped open its periosteum sheath. Maybe it did this in one place if the patient has a simple fracture, but it could have happened in several places. Tibia fractures also frequently involve damage or fracture to the fibula. the thinner and weaker of the two lower leg bones. The broken bone ends can be sharp, and the wound may have left splinters or spikes of bone. If a surgeon isn't careful, a sharp bone end can penetrate right through her surgical gloves. But even if the bone ends are not sharp, they'll move around and jiggle any fragments or spikes. The torn periosteum, with its many pain-sensing nerves, will be flooding the brain with pain signals, and any additional movement will aggravate the nociceptors further, creating more pain. In addition, the periosteum's broken blood vessels will be bleeding into the area, and the pooling blood may pressure and irritate the surrounding muscles and other tissues, magnifying the pain even more. All that may happen even if EMTs have splintered our patient, immobilizing the bone to a certain extent. If they haven't done that for some reason, every movement, the joggling of the gurney or transferring our patient to an X-ray table, for example, will cause excruciating pain. All that pain has a reason, of course. It's the body's way of telling the brain, in no uncertain terms, not to move the injured limb. The brain has to keep things as still as possible down there. Only that way will healing begin and new bone matter be laid down to start fusing the break. That message has to be very loud and very clear, which explains why the pain volume is so high. Now, here's what happens once our patient is in the ER. Let's assume it's a big, busy city hospital, which is where the main analgesia studies were done. With all the activity, it may take a while for a nurse to do an assessment and triage the new arrival. A fracture patient who isn't in shock, whose blood pressure is not down, and who is not bleeding profusely won't be at the top of the triage, but he will be urgent. Everyone knows the level of pain here, but still, it will take some time for one of the ER docs to get around to him. If the break is so bad he needs surgery, he'll be medicated and up he'll go to the operating room. Otherwise, his leg will be immobilized in a large brace or cast, and he'll be fitted for crutches. And regularly, if the patient is black, he'll be given less pain medication than his white fellow human being. Not infrequently, he'll get no pain medication at all. That, by the way, is true for Hispanic as well as African American patients. In fact, the groundbreaking analgesic study of this sort was done on Hispanic fracture patients. I'm discussing African American disparities first because even though I readily understood that other groups were also subjected to disparate health care in equally serious and meaningful ways, as a black physician, my own experiences and thinking were initially focused on race issues. Also, because the racial divide is so exemplary of implicit prejudice, understanding how that works may be a key to unlocking the way prejudice works vis-a-vis other minorities. In any event, the bone fracture researchers were so impressed by their findings that they repeated their Hispanic study in a different city with black patients. After that, other researchers were sufficiently taken by those results that they began looking into post-operative analgesic prescriptions and found large disparities there as well. While most attuned doctors were disturbed by all of the unequal treatment disparity revelations on cardiac care, transplants, surgical procedures, and others, to me, as an orthopedic surgeon, it was the long bone breaks that really stood out. A bone break is about as simple and straightforward as an injury can get. It has no relation to culture or language or unhealthy lifestyle or whether African Americans might be adverse to some kinds of treatments. It simply must be fixed, and the considerable pain of it has to be addressed. Broken bones and analgesia are an ideal case to test whether the healthcare delivery system is functioning in an egalitarian way, as we expect it to, and the healthcare delivery system failed that test miserably. As Professor Jack Greger wrote in Unequal Treatment, after surveying the spectrum of healthcare disparities, bone break cases are particularly troubling. If you try to get at why this particular disparity happens, several explanations suggest themselves. One is the historical assumption that blacks do not experience pain the same way whites do. They have, as one 19th century medical account put it, an insensibility of the nerves. Endowed with a more primitive, robust resistance to pain, African Americans don't actually need as much pain medication as whites. Of course, this is utter nonsense, and nobody today would ever get up in a lecture and state such a thing. But it stands out in the historical literature. That belief became part of the culture of medicine at some level, and it's still out there in the background ambiance. Then there's the conscious or unconscious assumption that African Americans coming into the ER may be drug addicts, or at least may be seeking drugs. That is to say, you'd better be especially careful with narcotics when you're dealing with black patients. There's another background assumption at work too. An African American psychiatrist, talking about his white colleagues at a major West Coast teaching hospital, said, "I knew a lot of white psychiatrists who thought it was a truism that all black people were angry with whites, that all of their black patients were angry and mistrusting." Irving Allen, another African American psychiatrist in the Boston area, talks to black patients about how to survive in a medical setting. Be cool, he tells them. Be extremely careful not to appear hostile. But the fact is that patients in severe pain are often scared and angry. And doctors aren't different from other people, despite all their training. Confronted with that they perceive as anger or dislike, especially black anger, they will tend to back off, or at least not engage as they would otherwise. The doctors responsible might be, "I don't really want to deal with this. Let me get this cast on and get on with somebody else." And that too might impinge on prescribing the appropriate pain medications. All this is aside from just plain old subconscious or maybe even conscious prejudice. But even without these stereotypes and assumptions, blacks don't feel as much pain. They might be addicts or drug dealers. They might be hostile. Doctors will sometimes simply let things slip, especially in the rush of a busy ER. That happens vis-a-vis white patients too. Pain management often just isn't handled as well as it should be, but for African Americans it happens a great deal more often. How is it that fair-minded, compassionate doctors end up giving less pain medication to blacks than to whites for equally painful conditions? More bluntly, why do they allow African Americans to suffer more? The answer is that categorization and stereotyping are such elemental mechanisms of cognition that we can't get away from them, with racial identification being one of the primary classifications. And since in white minds blacks are more associated with negative attributes, that perception gets incorporated into normal patterns of understanding. Because these things happen subconsciously, they're automatic mental processes. It's no wonder that bias may be implicit and unrecognized, yet shows up starkly in medical practice. In the course of interviewing healthcare professionals for a study of disparate care, Harvard medical anthropologist Mary Jo Good talked with an African American attending psychiatrist who told her that, in his consultations on psychotropic medications, he often finds that primary care physicians prescribe less current drugs for their black patients. When he asks them why, they are baffled and unaware. But you don't have to be a medical anthropologist or statistical researcher to notice the phenomena. Here's a student incident report from the Focus newsletter. During team rounds, the resident referred to a black patient by her first name, removed her bedclothes, and examined her abdomen and breasts without drawing the curtain in a two-bedroom. The next patient, a white woman, who was called Mrs. Jones, underwent the same examination while she was carefully draped, and the curtains round her bed were drawn. Why are those white doctors treating their black patients differently? They do not know. They do it without thinking. Stereotyping is like a mental conduit that channels people away from considering those in outgroups as individuals. Other large forces that have the same effect come into play too. In this regard, medical anthropologist Good has focused attention on the culture of medicine itself. She has been especially interested in the way the medical world trains doctors to recognize disease. Good, who has been studying this subject for several decades, uses the term medical gaze to convey the essence of her assessment. By medical gaze, she and other social scientists mean the culture of medicine that conditions physicians to focus on the patient's physiological symptoms and biomedical indications and discourages them from taking into account the social context. As students, she says, doctors learn to value what medicine cares about and to discount the human side. Time pressures, the stresses of the work environment, and the need to see many patients all reinforce the experience of this so-called prescriptive approach to treatment. Another leading teacher and researcher puts it this way: doctors are taught that their own personal background and the characteristics of the patient should be excluded from consideration in the formulation of clinical decisions. Students learn this approach from their professors and supervisors, whom they emulate, and from the structure of the medical school curriculum. Many students are attracted to caring for the poor or working to alleviate minority health problems, but these kinds of humanitarian projects tend to become less important as they move on to clinical work in their third and fourth years and into their internships, where they are faced with making hard therapeutic decisions with potentially grave consequences. Operating from within this biomedical perspective, doctors find certain kinds of patients harder to treat. Patients may have problems that are exacerbated by their social circumstances, that get in the way of medical therapies. Patients may not comply with doctors' wishes and expectations. They may indulge in high-risk behaviors that obviate therapies. Patients of this sort throw doctors off from providing the care they have learned is most effective. Giving them optimal care requires exploration and insight into their individual lives, which physicians may not be able or willing to give and are not, in any case, trained to do. Such patients are frustrating and time-consuming in a medical environment that more and more demands efficiency. All this feeds into doctors' attitudes toward those they treat. The kinds of patients who bring these sorts of extramedical problems into their interactions with doctors tend to be more poorly educated and from lower socioeconomic groups. They also tend to be from racial and ethnic minorities. Over time, many doctors build or buy into stereotypes of these groups in ways that can and do influence diagnosis and treatment. One influential study that looked at physicians' perceptions of patients showed that doctors thought of African American patients as less intelligent, less educated, more likely to be drug abusers, less likely to follow doctors' orders, and less likely to enjoy the help and support of others while in treatment than their white patients. Even though the study was controlled for education level, income, and other potentially confounding factors, finally, white doctors felt less affiliation, that is, less friendliness, toward their black patients. Thank you guys so much for watching this video. Excuse my mispronunciation of certain medical terminology. I'm not exactly sure how to pronounce certain words that this excerpt had because it is, very unique to the medical field. So pardon me for that. But thank you guys so much for watching this video. Make sure to let me know your opinions down below in the comments, and make sure to subscribe to the channel so that you could continue on with me in my reading of racism in America. And once again, you guys, I'll be seeing you in the next video. Bye.